Good morning, good afternoon, good evening to everyone logged in from all over the world. It's indeed a great pleasure and honor to be here today to make this great presentation and to be part of this epoch event, the first ever virtual AOAC in the history of ACON. This is a topic I'm very passionate about. This was born out from a time when I embarked on a small project back in 2018, and while searching for the prevalence rate of psychosocial stress among healthcare workers in Nigeria, found out that the few available statistics were at variance, and hence decided to ascertain the general prevalence rate of psychosocial stress among healthcare workers. This culminated in the publication of my peer review article on psychosocial stress. The outcome was quite informative, revealing the global impact of psychosocial stress among healthcare workers, which too often has been ignored, with broad applications, thus serving as a catalyst for choosing this topic to present today, titled A Systematic Review and Meta-Analysis of Psychosocial Stress and its Risk Factors among Healthcare Workers. So let me move my slide. So my name is Dr. Charles Babajide Onigbogi. I'm an occupational health physician with about 21 years working experience in the Nigerian oil and gas industry with the NNPC Medical Services Limited, that's the Nigerian National Petroleum Corporation. I'm a member of ACOM's International and Transportation sections, a member of ACOM's E-Stress Working Group and Council member, ACOM Membership Communication Committee. I'm also a member of ICO's subcommittees on occupational health for health workers and on tuberculosis in health workers. I am currently the National Public Relations Officer of the Society of Occupational and Environmental Health Physicians of Nigeria, SOPHON, which is more or less the ACON of Nigeria. These are my affiliations. Apart from ACON and SOPHON, I'm also a member of the Society for Quality in Healthcare Nigeria. I'm a member of the Nigerian Society of Travel Medicine, also a member of the South African Society of Travel Medicine and the Pan-African Travel Medicine Federation. I'm also a member of the International Society for Quality in Healthcare, OSHA Africa, ICO, and these are also other affiliations I belong to, the universities I've attended, and my Medical and Dental Council of Nigeria membership. There are no conflicts of interest to declare. The opinion expressed and related educational content are author's own and does not reflect the policy of the Ministry of Health and the Ministry of Labor of the Federal Republic of Nigeria. I would like to acknowledge the great support received from my mentor and tutor, Dr. Srikanta Banerjee, who has been instrumental to my soft landing as I veered into the field of research work. Dr. B, as I've called him fondly, was my tutor during my Master of Public Health program at the University of Roehampton, UK. He has nearly 20 years of experience in the areas of public health and global health. He has worked at the Centers for Disease Control in the area of infectious diseases and has worked on public health projects worldwide. Also, he has experience in advising students about public health projects. I'm a living example of that. He uses his medical clinical expertise and his research acumen to guide his students. So what are our learning objectives for today? To describe the general prevalence of psychosocial stress among healthcare workers in Nigeria, provide generally acceptable data to make informed preventive and therapeutic policy decisions that might be applicable globally using meta-analysis of the few studies available with validated standardized instruments. And lastly, we'll be to explore and compare data with global trends in fostering best preventive measures and adding to the fund of knowledge. But why psychosocial stress and healthcare workers? Why bother? Why is it something of importance to discuss in a forum like this? Well, the answer to me is yes. I don't know what you think, but why not? There is a global shortage of healthcare workers at the moment, and it has reached a crisis peak in 57 countries, especially in Africa, Asia, and the Middle East. It is currently at 7.2 million shortage globally, and it is projected to reach 12.7 million by 2035. This is by WHO. Healthcare workers are faced with a barrage of challenges and work-related hazards, especially psychosocial stress, affecting their well-being and performances. General Assembly, United Nations, on the 10th of October 2019, adopted a resolution under the Universal Health Coverage to take action to protect healthcare workers from all forms of violence, attacks, harassment, and discriminatory practices, and to promote their decent and safe working environment and conditions at all times. WHO on the 17th of September 2020 launched a charter on health workers' safety, a priority for patient safety, calling for urgent and sustainable action globally in 5 key areas, which includes improvement of mental health and psychological well-being of healthcare workers and protecting them from psychosocial risk. WHO, together with ILO, brought out a policy brief on national programs for occupational health for healthcare workers, caring for those who care. This was launched at the 2020 World Patient Safety Day for all policymakers. Well, so who are healthcare workers? Healthcare workers are all categories of medical and non-medical health service providers, including health management and support workers, engaged in activities aimed at improving general well-being and health. They include doctors, nurses, midwives, pharmacists, laboratory scientists, non-medical technicians, personal care workers, community health workers, cleaners, drivers, hospital administrators, social workers, and so on. So, do any of the scenarios here look familiar to any of us? These are healthcare workers. You can see what we are going through. A picture, they say, speaks a million words. Since the original research was on Nigeria, I thought maybe I should put up the map of Nigeria, where it's located is in Africa, precisely in West Africa. The size is almost 4 times the size of the UK, or slightly more than twice the size of the US state of California. It has about 201 million people as of 2019, making it the 7th most populous country in the world. English is the official language, and we have 3 major local languages, Yoruba, Hausa, and Igbo, with about 250 different ethno-linguistic groups. So, what is psychosocial stress? It is the response people may have when presented with work demands and pressures that are not matched to their knowledge and abilities, and which challenge their ability to cope. Psychosocial stress among healthcare workers has been hugely neglected, with healthcare workers presumed to be immune to hazards. Frequent changes in work organization and pressure to consistently deliver quality healthcare services at a higher level affects healthcare workers' well-being and productivity. Psychosocial stress is rapidly becoming an occupational health epidemic, negatively impacting on workers' health and organizational health indices, lost man hours, sick leave, absenteeism, and poor productivity. I added this slide to do a recap on the physiological pathway of psychosocial stress. and thought there is no better way than using the allostatic load concept, which was described by Bruce McEwen and Elliot Steller in 1993. Allostasis is simply the state of readiness that keeps an individual in equilibrium in the face of a presumed threat and anticipated demands. The outcome of the cumulative burden of repeated chronic stress and life events is known as allostatic load, which involves the interaction of different physiological systems at varying degrees of activity to maintain homeostasis so that the body can function efficiently. However, when environmental challenges exceed the individual's ability to adapt and cope, then allostatic overload concept ensures. So naturally, most times we go through stress, we're able to cope and adapt. A time comes when the stress becomes overbearing and we're no longer able to cope. That is the allostatic overload. The hypothalamus pituitary adrenal axis is responsible for our stress responses with the release of corticotropin releasing hormone, adrenocorticotropin hormone, which brings out our stress hormone, especially cortisol, that determines our fight or flee response. So talking about the global impact of psychosocial stress. In the year 2000, over 59.8 million healthcare workers globally were exposed to occupational hazards, especially stress, resulting in 850,000 deaths. Then between 2000 and 2009, psychosocial stress accounted for 30% of all work-related illnesses among the European Union member nations, with about 265 billion euros lost annually to stress-related working days lost and poor productivity. About 22% of this figure were linked to healthcare workers. With growing global concerns, Canada in 2009 reported a growing impact of psychosocial stress among healthcare workers at 28%, higher than previous decades. In a study in India, psychosocial stress was estimated at 69.7% among healthcare workers, contributing to about 60% of all lost working days in the whole of India. So the Nigerian experience, with a population of over 201 million people, has one of the largest stocks of human resources for health in Africa, with 1.95 per 1,000 population. And there are at least 3,827 doctors per 10,000 populations and 14,524 nurses and midwives per 10,000 population. Psychosocial stress among healthcare workers in Nigeria has been hugely underreported and perhaps neglected. Few studies available published on the prevalence of psychosocial stress among healthcare workers in Nigeria, in most cases, have been incomplete, and the statistics have been far apart with wide margins. There are currently no pooled data available assessing psychosocial stress prevalence and its risk factors among healthcare workers in Nigeria. Hence, the need to close this knowledge gap and establish the general prevalence of psychosocial stress among healthcare workers in Nigeria in order to prefer informed preventive and therapeutic policy decisions. So what was our study design? We used, since it is a meta-analysis by the title of the presentation, it was appropriate for this kind of study because meta-analysis is a method used to combine or pool the effects and result of different outcomes from a group of similar studies in order to obtain a quantitative synthesis, which will be a meaningful description of the set of studies, thereby increasing the power of statistical analysis or significance. So keywords used were psychosocial stress risk assessments, healthcare workers, Nigeria. We had literature searches from Google Scholar, PubMed, Medline, Journal of Occupational and Environmental Medicine, International Journal of Public Health, and some other supplementary information from WHO, ILO, and ICO conference proceedings. Based on a systematic and meta-analysis review nature of the study, and we're using published secondary data, ethical approval was not necessary at this moment. In our inclusion criteria, we used the PRISMA guidelines for reporting systematic reviews. PRISMA, for those who are not aware, is an acronym for the preferred reporting items for systematic reviews and meta-analysis. This was developed in 2009. It evolved from the older quorum, that is quality of reporting of meta-analysis guideline, which was initially developed in 1999. It is an evidence-based checklist set of items used to summarize reports in systematic review and meta-analysis. So the studies were carried out in Nigeria in English and between January 2000 and September 2018. Only psychosocial stress prevalence articles that use validated and standardized psychosocial stress assessment instruments and evaluated psychosocial stress-related health outcomes and risk factors were included. At least one co-founder must be used, be it socio-demographic, biological, work organization, lifestyle habits, or socioeconomic co-founders are allowed. Opinion articles, abstracts, book chapters, and review articles were excluded from the study. So this is our PRISMA flow diagram for inclusion criteria of the research studies we included. So from the identification stage, first stage, we got 122 records through database searches and other documents from Google searches. Out of these 122 records, 45 were duplicates and they were removed, remaining 77 records. After further screening, 60 records were excluded. 20 of them were studies on undergraduate students. Another 11 were studies on postgraduate medical and data students. And 29 were on teachers in healthcare institutions across Nigeria who were not necessarily involved in clinical practice. So out of the remaining 17, we now started full test article assessment for eligibility for the study. 9 full test articles were excluded. 7 of them did not indicate the type of validated and standardized psychosocial stress assessment instrument that were used, and another 2 did not document prevalence value for psychosocial stress in percentages. So we're now left with 8 articles, which were eventually included for the psychosocial stress study meta-analysis. Of course, the number of articles also went ahead to determine what kind of model we use in our meta-analysis. So this is a breakdown of the studies we included. Our table 1, psychosocial stress prevalence rate, which shows us our setting, study design, the sample size, the percentage of prevalence rates, and the risk factors that were reported. 8 articles. Locally, they represented almost the 6 geopolitical zones of Nigeria. So we had an overall coverage. All of them were cross-sectional studies, and various risk factors were documented or reported. In our table 2, shows us the co-founders measured in the 8 articles, the assessment instruments used, and of course, the psychosocial stress health outcomes that were reported. The instruments range from job content questionnaire, stress assessment questionnaire for hospital nurses, job demand control questionnaires, job stress and workers' productivity, general health questionnaire, general practitioners' job stress inventory, and so many others. So this is just a summary of the 8 articles that were included. Yes, they were carried out in Nigeria between the year 2000 and 2018 with a combined study population of 1,790 healthcare workers, averaging 224 people per study. All the studies were cross-sectional, involving all cadres of the healthcare industry, using validated psychosocial stress assessment instruments and observed various risk factors for psychosocial stress. The studies also elicited various psychosocial stress-related health outcomes, ranging from emotional symptoms, personal behavioral symptoms, and physical symptoms. And of course, they all control for at least one co-founder, as we saw in table 2. So, what were our results? Because this was a meta-analysis and we had just 8 articles, it was obvious that heterogeneity will be a factor. And in order to show the significance in statistics of this heterogeneity, we had to test the extent of heterogeneity. For this reason, we use the concurrence Q test and the percentage of inconsistency or variance. They were all conducted. As we know, concurrence Q test is a weighted sum of squared differences between individual and pooled study effects, which is a classical measure for heterogeneity. This is to test the null hypothesis. If the p-value threshold of the test is low, that is less than 0.05, we can reject the null hypothesis that the study is homogeneity and accept that there is statistical heterogeneity. Yes, there are limitations in the concurrence Q test because the power can be low when there are few studies. Hence, it is usually assessed alongside other tests, like you have the percentage of inconsistency or variance and or meta-regression model review. Now, because of the high variation between studies, that's high percentage of inconsistency, distribution of effect sizes and the small sample volume for this meta-analysis, a random effects model was deemed appropriate for assessment and to control for unobserved heterogeneity. The other model would have been a fixed effects model, which normally involves a larger sample volume. Luckily, our percentage for variance and inconsistency was quite high. And with a low volume of sample size, the random effects model was used. From this study, the pool prevalence rate of psychosocial stress among healthcare workers in Nigeria with a sample size of 1,790 was 61.97%. The 95% confidence interval between 41.01 to 80.82 using the random effects model. You can see from the table there, showing you the random effects tabulation. So I mentioned earlier, where we use the concurrence Q test and where we also search for the percentage of inconsistency or variance. Here you can see that our percentage for inconsistency was 98.78%, which was quite significant. This percentage is used to further quantify the extent of the heterogeneity in meta-analysis, especially when the sample volume is small. It provides an estimate of the percentage of variability in results across studies that is due to real differences and not due to chance. When the percentage of inconsistency or variance is between 0 to 40, it is insignificant. Between 40 to 70%, it is moderate. Between 70 to 80, it is substantial. Then 80 and above, it is considerable, very high heterogeneity. Of course, it also has its own limitations. And where necessary, a meta-regression model is further conducted. However, with a concurrent skew tabulation, we had enough p-value that was less than 0.0001 that has statistical significance. So there was no need to do a further meta-regression analysis. So to further illustrate heterogeneity in meta-analysis, graphical representations using the funnel scatter plot, which is on the right of the screen, of effect estimates, and forest plot on the left, we also performed to show us how effective the study was. The funnel scatter plot on your right screen is primarily a visual aid for detecting publication bias or systematic heterogeneity. The plot should ideally resemble a pyramid or inverted funnel. Once the inverted funnel is symmetrical, that means this exercise or research conducted arises from a well-behaved data set in which publication bias is very unlikely, as seen in this meta-analysis. Each dot, there you can see some orange dots, orange round dots, represent a single study. Like each study are those dots. The y-axis is usually the standard error of the effect estimate, while the x-axis shows the result for the study, which is sometimes expressed as an odds ratio. The forest plot on the left side of the screen addresses the same question of heterogeneity with a graphical display representing a meta-analysis of estimated results. You can see the rectangles are the prevalence rates of individual studies. The 95% confidence interval are the horizontal lines you see there, while the pooled prevalence rate is a diamond shape for all the articles together. And you can see we're using the random effects model. It shows us a balanced scale, balancing all the articles together. This just shows us that our study was from a good data set with little likelihood of publication bias of any form. As we did for the psychosocial stress prevalence rates, we also did for our risk factors and stress-related health outcomes. From these 8 articles we did, we found that work overload was the most prevalent risk factor with an overall prevalence rate of 67.40%, and 95% confidence interval between 33.25 to 33.76. Among the stress-related health outcome, only headache with neck and back pain had a percentage rate we could hold as an outcome with an overall prevalence rate of 93.26%. Other risk factors were lack of resources and equipment at 62.37%, poor communication and attitude at 50.37%. So, as we have seen, the general prevalence rate of psychosocial stress among healthcare workers in Nigeria was 61.97%, which is very significant and goes beyond available literature prevalence rates in the sub-Saharan region, which is a cause for concern. Similar nationwide studies among healthcare workers in Rwanda, Ghana, and Uganda showed psychosocial stress prevalence rates at 15.3%, 17%, and 21.5% respectively. While psychosocial stress prevalence rate among Pakistani healthcare workers was 26%, at variance with current meta-analysis that we have just seen, it was 69.7% among healthcare workers in India, their next door neighbor. Studies while examining the occupational risks and illnesses among healthcare workers in Brazil and Chile found the psychosocial stress prevalence rates at 71.1% and 57% respectively. NHS UK reported a psychosocial stress prevalence rate of 16% among NHS healthcare workers, while a prevalence rate of 22% was recorded in a nationwide study among German healthcare workers, all within the same period covered by the current meta-analysis. The differences in levels could be due to healthcare management systems and organizational structures of hospitals obtained in different countries. The analysis also further established that work overload was the most prevalent psychosocial stress risk factor, which was consistent with findings from similar regional sub-Saharan studies. Other risk factors were poor communication, staff attitude, lack of resources and equipment. And among psychosocial stress-related health outcomes compiled, only headache with neck and back pain were evaluated with an estimated prevalence rate of 3.26%, which was also consistent with previous sub-Saharan studies. So you can see that apart from the risk factors and the health outcomes that were in line with almost all the studies that were reviewed globally, only the rate itself of psychosocial stress were different among the countries. So what are the strengths and limitations? Regarding strengths, availability of a poor prevalence rate of psychosocial stress among healthcare workers in Nigeria alone, using a rigorous methodology and PRISMA protocol useful as a baseline estimate in future studies is a good strength. The meta-analysis approach enhances the validity and the quality of peer-reviewed articles analyzed, overcoming small sample size and statistical power constraints, thereby increasing statistical significance. For limitations, of course, we were unable to assess full tests of some articles for more statistical power and association and critically review methodological quality used in most articles. As with most meta-analysis, heterogeneity itself can pose a limitation. And of course, many articles do not include prevalence percentage values for most of their risk factors and health outcomes, hence they cannot be included in direct statistical calculations. So in conclusion, this meta-analysis suggests that psychosocial stress is a common feature with alarming rates among healthcare workers in Nigeria. Psychosocial stress environment influences the overall well-being of healthcare workers and organizational health indices, such as reduced productivity and sickness absence. Allostatic load explains the cumulative effect of stress on the physical body. Validated and standardized assessment instruments are required to assess psychosocial stress prevalence and its risk factors to yield more consistent results. It is necessary to further provide healthcare organizations and occupational health practitioners with evidence-based baseline prevalence estimates. These findings necessitate advocacy from all stakeholders to identify and implement effective measures to reduce psychosocial stress among healthcare workers, not only in Nigeria, globally, in line with global best practices. What we can do at the interim. We can build a solid team support system within the healthcare workers community. This will help us a lot to buffer all the stress activities that we are going through. We can enhance capacity building in psychological and psychosocial competencies among healthcare workers at the highest level, that is the supervisory and management levels, so that we are able to identify if our colleagues are undergoing stress and know what to do to curb it in the bud and provide succor for healthcare workers. And of course, we need to have a paradigm shift We need to have this proactive nip-it-in-the-bud approach. We should no longer wait until we become extinct on the face of the world. If we don't take good care of ourselves, who would? Medicus custodiante. I would like to end this presentation using this phrase from WHO I saw. Protecting the occupational health of healthcare workers is critical to having an adequate workforce of trained and healthy health personnel. Is by WHO. As healthcare workers, the way forward is no longer physician heal themselves, but physician protect themselves. I now yield the floor and say a big thank you for allowing me to occupy your precious time and patience. Wishing you the best as you go on with the 2021 virtual conference. Thank you very much once again. If there are any questions, queries, additions, I'm available to take them on. Thank you very much.